we now have a third presentation taken from the abstracts, and this is about gram-negative bacteremia risk factors, prophylaxis and treatment. It will also be presented tomorrow in the e-poster Arena 6 at 1:30. And the speaker is Dr. Ekdal.
Perhaps I can correct something. I said the Lancet paper is available today, but actually it's available tomorrow as we do that. So that's a technical thing, but I think you have to be aware about that. So you should not disclose the results until tomorrow.
Thank you.
Sorry about that.
Dr. Joachim Isedal is the one who is who will give the next presentation with the title Drug-resistant bacterial patients urine students raise the risk of drug.
Hello everybody, my name is Joachim Isedal and I'm a PhD student at Karolinska Institutet. I'm also a junior physician at Skåne University Hospital in Malmö, Sweden. And I've been working on this project together with Per Sparén, Anders Kärnholm, Karin Tigmark Gisell, Christian Giske and Pontus Nauclear. All affiliated with either the Public Health Agency in Sweden or Karolinska Institutet. It's a great pleasure to be here today. And the theme for this presentation is how a finding of ESBL-producing bacteria in the gut or urinary tract affects the ensuing risk of having an invasive infection with these bacteria. It's a register-based study, and I will shortly go into more about what that means. But just to provide some background, ESBL-producing bacteria or gut bacteria that break down the very antibiotics that physicians use to treat sepsis or patients that are at risk for invasive infections when they come to the hospital. And these bacteria are on the increase globally since a couple of decades. It's often said that they pose a future public health risk or problem, but the truth is that they already today compromise public health with tens of thousands of deaths globally each year. And traditionally, these bacteria are not very prevalent in Sweden. There's about a 5% prevalence in the population. And therefore, when patients present to hospitals in Sweden with a history of having been treated in hospitals in other countries, they will be screened for carriage of these bacteria in either their gut or their urine. And also some other patient populations are screened, such as those that have a recent intensive care unit stay, or patients that have urinary catheters for a long time. Anyway, we used a comprehensive register of all findings of these bacteria in Sweden to look at the risk over time. After having a previous finding of these bacteria in a fecal sample or in urine, what is the risk of them developing an invasive infection with these bacteria? And we also contrasted this risk with the risk in the background population. And also within this group of patients, we looked at how antibiotic consumption in outpatient care, how health status and social factors such as education influence the risk of developing an infection. So once again, the register setup is kind of complex at the start, but it starts with 21,000 individuals in the Public Health Agency register, and these should be all patients that have had a finding reported in Sweden between 2007 and 2012. And these were then linked with other registers at different government agencies in Sweden to get data on follow-up, on comorbidity, on other factors such as education, and then to select a population from or a comparison population from the background population as a whole. And these are our results. Among 16,000 individuals that had a finding in urine, 482 developed an invasive infection during the follow-up time, which was up to 6 years, as you can see in the graph. In feces, those who had a fecal finding had a lower risk. 175 of them developed an invasive infection. And then in the comparison group, there were 45,000 people, but only 3 of those developed an invasive infection. And that's reflected in the blue graph that you can see on the bottom. Then in urine, as you can see, the risk is very high in the beginning, and then it decreases exponentially over time, but it's still elevated up to 6 years, as you can see, whereas in feces, the risk seems to plateau after about 3 years. And then looking at risk factors among those who had a previous finding in urine or feces, age, which I think is interesting, did not seem to influence the risk. The residence county of the person did not influence it, and education status did not have a clear influence either. As far as comorbidities goes, there were a few comorbidities that were associated with risk of invasive infection, but urological disorders stood out with the risk was more than 3-fold, as you can see. Then, when it comes to outpatient antibiotic consumption, once again, this is not in hospital, but only what the patients have gotten from the pharmacy. There was a tendency of increased risk in the first 30 days for some of the antibiotic groups, but there was no evidence of increased risk in the longer term, so that in our data. To sum this up, the strengths of this study are that we managed to get 21,000 people with a previous finding into the cohort, which is a considerable size. And then the nature, of course, of our data, being registered data, we could get very good follow-up information on our cohort, and also we could get certain exposures that are difficult to capture in more conventional setups. And then, of course, the fact that we were able to map the risk over time and see how it develops. And the main finding is, of course, as the graph showed, that the risk of an invasive EP infection after a previous EPD finding in feces or urine decreases rapidly, but it's still elevated for 3 years in the case of feces and up to 6 years in the case of urine. And then neurological disorders were predisposive, and antibiotic consumption in the outpatient setting did not seem to increase the long-term risk of invasive infection in our data. Thank you.
Thank you too for this nice presentation.